Dear representatives from the BRCCH, dear audience, it's an honor and pleasure to present you our achievements from AI-driven planning, reconstruction, and clinical assessment to advance accessible cleft care. Since ever, cleft, lip, and palate has been with mankind, posing significant burden and challenge to both patient and doctors. It's non-preventable, and beside human, also mammals are affected too. So early lip and palate closure seems to be just a vulnerable step in the construction plan of the face. 1 in every 700 newborn is affected, making it the most common craniofacial birth defect. It affects all fundamental functions, eating, breathing, speaking, hearing, an important social function, self-perception. In 2020, BRCCH called for innovative healthcare solutions that leverage the emerging use of smartphones and AI technology and making the care more accessible in resource-restricted settings. That was the moment when Barbara and me, together with Markus Gross, Goslar Reddy, who is here today, very grateful, and Andre, also here today, formed a consortium, and we got the generous funding from BRCCH to start the digital transformation for cleft care. And we were gratefully supported also by additional eminent clinical partners in Switzerland and India. Now, what is the unaddressed need that can benefit from these new technologies? The relation between the exact anatomical shape, the optimal intervention, and the achieved outcome remains elusive still today, mainly because we have a lack of data on all levels. So we had the vision to alleviate the treatment burden by using AI and technology for multiple purpose along the care pathway, which we will present you now. First, when the baby is born, the opening in the palate, that is the cleft, is really wide. And we know the reason for this. It's the tongue. Therefore, if you create a plate that hinders the tongue to go into the cleft narrows spontaneously. However, traditional manufacturing of such plates poses danger to airway, and it's labor intensive. And this is why I seek the help of Barbara.
Yeah, this brought us to the idea to transform this workflow into a digital and fully automated one. So we wanted to have an algorithm that takes as input a 3D shape of the cleft palate and gives us as output the 3D printed plate that fits perfectly to the person-specific intraoral anatomy. Now, we wanted this algorithm to handle 3D shapes regardless of how these shapes were captured. Although we were aiming at an automated method, we wanted to support clinician-guided control over the shape of the plate. Now, the method for the plate computation follows a set of processing steps, and this algorithm has mainly been implemented by Till, who is also here in the audience today as part of his PhD thesis. So we start with an AI-based landmark prediction, followed by steps for surface registration, cleft filling, and volumization, and these are based on classical geometric modeling approaches. Now, for the landmark prediction, we were using a two-step approach because we wanted to estimate landmarks on meshes of arbitrary topology and orientation. So the core idea is basically that we first predict coarse landmarks using a diffusion net, and these coarse landmarks are then used to align the scans, and in a second step, we predict, or we have another diffusion net to predict higher accurate landmarks. So this whole pipeline is also visualized in this video, what you can see here is the 3D shape of the cleft and palate. So in a first step, we have the landmarks that are predicted with our model. And then once we have these landmarks, we can use them for the surface registration. So the green part that you have seen previously is or corresponds to the contact area of the plate, and the yellow part was basically bridging the cleft. And then we have the cleft filling step, where we basically compute or connect these ridges. So we bridge the cleft, and we are trying to mimic the shape of a healthy palate. Then from this step, we get this thin sheet, and we have to compute the volume such that the plates can then be 3D printed. And at this step, also the control functionality comes in. So a clinician or a user can add additional landmarks, for example, to carve out certain areas. There are additional control functionality, like to define the thickness of the plate or the size. One can add additional features such as ripples on the surface or an additional hole. So these are all representing the control functionalities for the user. So we then get this the final plate. Now, in order to bring this from a research prototype into clinical use, we have developed a graphical user interface as part of a Blender plugin, and this software reduces the time for the plate fabrication from about 40 minutes to 5 minutes, while about 1 to 2 minutes are manual involvement by the user. Now, with this software, the team in Basel have computed diverse plates for many patients. So these plates can then be 3D printed. So what you have seen before was the print lab at the University of Basel, and the plates can then be used in the treatment. So they can be inserted into the mouth of an infant where it just holds due to suction. So these plates are printed with a certified biocompatible material, and the whole print takes about 50 minutes.
Yes. Now, how can we use smartphone? How can we translate this automated planning into clinic by use of the smartphone? So first we connected this automated planning to the traditional workflow of impression taking by using the smartphone simply as a low-cost 3D scanning tool or device for the impression. Because this allowed us immediately to translate this first achievement of the automated planning into clinic with our colleagues in Hyderabad. So we set up this automated planning and printing pipeline together with Professor Reddy and Hemadi Nandan, who is also here, the orthodontist at the hospital in Hyderabad. And the clinical results showed that the spontaneous cleft narrowing showed to be equally effective for the low-cost smartphone solution as compared to the extensive intraoral scanners that has been used before. So the automated plate reduced the cleft width and area to about half of its initial size within 3 months of use of only one plate that has not been adapted and which needed 5 visits. So this achievement was recognized by Harvard with the AI Clinical Impact Award in 2015. Now the next question, can the smartphone help us to go directly from a photo to 3D? Now conventional photo taking in dentistry needs a lot of hands for retracting the cheek and having optimal lighting. So we therefore simplified and improved photo taking by designing a self-retracting cleft photo mirror. That gives full view by use of only a single operator, resource restricting settings, isn't it? Thus, we optimized the condition for direct photo to 3D, which was, again, Barbara's task.
Yeah, so we wanted to turn a smartphone into a 3D scanner. And as input, we get a video which is captured through this mirror in a freehand and uncontrolled manner. So what we then get are images from different viewpoints, here indicated by these red boxes. And now what we want to do is find the 3D shape that best explains all these observations. Now, this is a common problem in computer vision, and solutions are largely based on an algorithm called structure from motion. So structure from motion, or SFM, basically first estimates camera poses from overlapping views and then matches visual features across the different frames or the different observations. And from this information, we can then reconstruct a 3D point cloud of the shape. Now, when we use classical approaches from vision like SIFT and superpoint, superglue, we can observe that these reconstructions fail for our input that we have. So what makes our input so challenging for the reconstruction? And there are actually many factors that play into this. So one factor is that we have only limited viewpoints. So we are only capturing a narrow angular range. So, but maybe even more importantly, we have to deal with low feature anatomy, and where we only have a few landmarks which can use to find correspondences across frames. And this is even more challenging because we have lots of specular reflections. So we have wet tissue, we have saliva, we have dynamic effects from the saliva. So this makes it really difficult to find these corresponding local matches. Now, these specular reflections makes it also very difficult to use depth sensing as an additional input. So the depth values that we get are very unreliable because of the reflections, but also because we are capturing it at a very short distance. So in the end, we have to rely on RGB input only. And another factor actually that makes it very challenging is that we have that we can have different capture conditions across acquisitions. So for example, across acquisitions, the illumination can change and so on. And we want the method in the end that is robust to all inputs and all different types of capture conditions. Now, in the first year of the project, a method was developed which was designed for low texture region, which is called Lofter. And we applied it to our input, and as you can see, this worked already quite well. But the 3D reconstruction, this point cloud, is also very noisy. So this brought us to the idea to integrate domain knowledge. And what we wanted to do is to basically develop a shape prior of the cleft and use this to improve the 3D reconstruction. So in order to do so, Andreas and his team in Basel, who are all here today, they have built up a 3D cleft database of about 500 patients, and we then used a subset of this data to train a shape prior using a model that is called DeepSDF. Our algorithm then first takes or pre-processes the input video. So we have an AI-based masking to extract the relevant area. We have also a subsampling step to select the frames. And then we have the initial Lofter reconstruction, which gives us a sparse point cloud. And then we have the iterative refinement of this reconstruction by using our DeepSDF shape prior. So finally, at the end, we compute the dense reconstruction, and from this point cloud, we can then extract the 3D mesh. Now, we observed that this works quite promising for selected acquisitions. So we achieved for selected acquisitions errors in the sub-millimeter range, especially on the relevant region on which is the plate contact area. But we also observed that the quality depends or heavily depends on the input. So it was not robust across different inputs and acquisitions. And exactly this robustness is a key requirement for subsequent clinical use. So last year, foundation models for 3D reconstruction have been introduced in the vision community, including, for example, VGGT and MASTER. And these foundation models, they solve a broader geometric reasoning problem by inferring the underlying 3D scene that basically generated all these, or that has been generated all these different observations that we have. So you can think of these foundation models as using global multi-view context instead of trying to solve a local matching problem like Lofter is doing. So we have evaluated all these different methods on curated data sets, and we basically found that we get the best camera poses and the best reconstruction errors using this MASTER SFM approach. So it works in terms of quality or accuracy. It is quite comparable to our previous approach, the Cleft Lofter. So Lofter is our shape prior, but it works much more robustly. So in general, also VGGT, all these foundation models work more robustly across input and acquisitions. So let me show you one example. So this is an input video which is captured via this mirror. And at the left, you can see the ground truth 3D shape, which is the intraoral scan. In the middle, you can see the 3D reconstruction with this MASTER SFM approach. And on the right, the errors are color-coded. So here, blue and green is good. And this is actually the relevant region for the plate computation. So this corresponds to the contact area of the plate. It's exactly where we want to have high accuracy, and we get larger errors near the boundaries, which is acceptable in for the plate application. All right, but this is a promising trade-off actually between accuracy and robustness.
Yes, and during the project, we also worked on standardizing and automation of the 3D shape and analysis to answer basic knowledge questions. So we could clarify, for instance, that cleft patients show normal palatal length but excessive width, thus making the cleft narrower with the use of a passive plate really makes sense. We identified in which part of the palate there is a true deficit of tissue, because this is interesting for us as surgeons. And we found that it only needs 12 weeks of plate use to achieve most of the narrowing. And that the narrower and more normal the palatal cleft gets, also the more normal the nose gets, which is also very important. And after 12 weeks of plate therapy, the surgical closure needs only to be half as extensive as without a plate. And that brings me to our last chapter on how this all can reduce the healing burden. Because we know well that the less extensive the surgical trauma, the better the long-term outcome, the growth of the patient is. So we first introduced a surgical technique that stopped leaving open wounds at the end of surgery, which is still today quite common. However, we still had to make 3 parallel suture lines. But in 2023, we made the first complete repair of lip and palate using only one surgery and only one single midline suture. And the plate fabrication was instrumental to achieve this. And it was a major breakthrough. And also instrumental to this was our exchange and advice with Altaf Hussein, who collaborated with us, and with whom we published about how to lengthen the palate with a single midline suture. So we are now able to close the entire malformation of lip and palate by using one automated plate for 3 months and one surgery at 10 months, which leads just to one single suture. And this principle is repetitively applicable to all patients. It works in all patients with this type of malformation. Now, how does it spread in the cleft community? So, for example, our colleagues in Plovdiv in Bulgaria, around Yuri Anastasov, they started this year also implementing the automated workflow for plate fabrication, and they use it now in clinical routine. Or in Lahore, Pakistan, Ghulam Fayaz started now to do the palatal repair exactly as we showed without additional incision when it's feasible in his patient. They do not receive plates, obviously, because they come from far. However, he's excited and he shares his experience in the world's largest cleft surgical WhatsApp group. So yes, it spreads. So where do we go in the future?
So this multi-investigator project marks an important step towards AI-based 3D technologies for cleft care, but we are not done yet. So this project triggered several follow-up research projects where we work towards AI for holistic 3D cleft lip and palate modeling. So one example is our ongoing work on on how we should, or what kind of representations we should use in our models. So we are looking into implicit shape models which offer us certain advantages compared to traditional mesh-based approaches. And we want to use this especially for our shape prior, which gives us potentially also better reconstruction accuracy. So another aspect is once we have a better representation of the cleft shape, we can actually also explore fitting the shape directly to the image. So instead of using the structure from motion and classical 3D reconstruction approaches. So this is indicated by this second image. And we are also exploring the use of synthetic data, which potentially can improve these shape models, but it could potentially also be used for fine-tuning these foundation models that I've presented before. So another research area or project was focusing on infant faces. So we have developed a face model learned from data for infants, which can then be used for cleft care. We have also learned an anatomical model of the full head. So we have also learned an anatomical model of the head, and having such a learned joint model allows us also, for example, to infer underlying bones just from the facial surface alone. And it can also be used for data completion. For example, when we have only partial data available, we can compute full heads using these learned models. So this is really just a starting point towards our bigger vision of having these more holistic shape models for cleft care.
Yes, and today we both feel blessed and deeply thankful having worked over the last years together with our teams and all our international partners to transform cleft care, and having received this generous support from BRCCH to make it happen. So I thank Benito, Prasad, Yoriko, Maren, Dieter in my team really deeply. Thank you very much.